You want to do it? All the cool kids are doing it. I'm calling the Group Healthcare Committee meeting to order at 8:31 a.m. First on the agenda is the roll call. Could you please do the roll call?
Yes. Human Resources Director, Shauna Halterman.
Here.
Sparks Police Chief, Chris Crawford.
Here.
Acting Chief Assistant City Attorney, Jessica Coberly.
Here.
SPPA, Rachel Llewellyn-Anthem.
Here.
IAFF, Chris Hartwig.
Here.
OE, Leanne Roloffs.
Here.
We have a quorum.
All right, thank you. Just a reminder, because this is a new venue for us, the voting members up front, if you would turn your microphone on, that way the recording can hear you. Anybody else who is coming up to speak during our public comment portion needs to come up to the podium so that it's recorded. All right, the first business item is public comment. Any members of the public that would like to speak? Do we have any cards? I do not. Okay. All right. Being none, we'll move on to approval of the agenda. That's an action item. I am seeking a motion for an approval of the agenda.
Chris Hartwig, IFF, motion to approve.
Is there a second? Oh, so, yeah, it's on the tablet.
Chris Hartwig, IFF, motion to second. Do I have to
Put it on
press a
there,
button?
yeah.
Sorry.
Go. All right. We have a motion and a second. Any further discussion? Seeing none, please vote on your voting tablets. The people that are up there are actually alternates on the screen, so it passed unanimously. Moving on is item 5.1, consideration and possible approval of the minutes from the Sparks Group Healthcare Committee from January 15th, 2026. Can I get a motion for the approval of the minutes? We have a motion by Chris Hartwig and a second. Rachel, I'm going to get your name right at some point. Llewellyn-Anthem? Hey, okay. Please vote on your tablets. All right, motion passes unanimously. Next item is 6.1, announcements from the chair. Few things for you today. We have updated the instructions for the healthy lifestyle claims on the city's website. If you do a claim through the portal, they are now asking that you include the healthy lifestyle claim form. And the instructions say just that. Also, we have a new chief officer's alternate, Nick Claich. And if you're coming in the past, we used to have to make sure all the doors were unlocked when we were downstairs. Here, you should be able to come into the main public entrance in the morning. And that is it. Are there any announcements from the members? Item 6.2. None? Then we'll move on to item 6.3, which is a report on the Group Healthcare Fund from the Sparks Finance Department for fiscal year 2026. Wayne?
Good morning. For the record, Wayne Weber, Sparks Budget Manager. This report is the actuals through July through February. So far this year, we are trending on the positive side. Nothing really has jumped out we have some ebbs and flows every month, but for the most part, at this point, the fund is looking like we expected it to, actually a little better. And I can answer any questions on the financials. Sure.
Any,
Leanne, OE3. Wayne, can you give us just a little bit of knowledge as far as the fund goes for at what point would we worry that the fund balance is getting too low?
Well, I think what we need to look at is the ending net assets. As you can see, we ended fiscal '25 with $11 million, which if you average out the coverage, that's about 9.78 months of coverage, which is really good. So there was a time when we were negative. Now we're positive. So as we're trending, the last couple of years, we've been trending in a positive way. So you can see we've budgeted actually to be a little lower at 8.66, but right now we're ahead of budget, but we still have 3 months to go.
Thank you.
all right, any other questions for Wayne? All right, thank you, Wayne. Next is item 6.4 on the healthcare cost analysis review dated January 2026, presented by LP, Nate and Lloyd, and they are doing another presentation later on potential healthcare options. So this is their regular presentation that they do every time. Nate.
All right, thank you. Nate Kerr with LP Insurance for the record. Here to go over the group health plan report for City of Sparks for January 2026. Standard report, turning to Exhibit 1, employee enrollment is down a little over 2% at 522. Those employees carrying dependents, also known as dependent units, probably should, there you go, is relatively flat at 349. Employee claims on line 12 were up 10% at $656 per employee per month. Line 20, the dependent cost was up about 6% at $1,414. And combined employee and dependent on line 28, the month of January for active employee enrollment so far is up about 8.5%. Retiree exhibit, enrollment line 1 is relatively flat at 141 retiree onlys. Those retirees carrying dependents is down about 1 point at 70. Interestingly enough, though, the total number of dependents is flat. Line 12, the composite cost for retiree only was down about 26% at $945. Line 20, the dependent claims were up about 14.5% at $1,431, and combined down at line 28. Overall retiree cost for the month of January compared to the prior period was down about 13% at $1,656 composite. This is the exhibit where we simply add the two together for total claims all in. So I'll call your attention down to the bottom there at line 31. Through the month of January, our claims cost is up about 6.5%, averaging $1,604 per employee per month. Total plan cost is where we bring the fixed cost into the claims cost for a total all-in for the group health plan. For the month of January, I'll call your attention down to line 31. Overall, all-in costs were up about 6% at $1,770 per employee per month. Caveat, as always, it's 1 month, right? We're only the first month of the year, so. And our last one is our IBNR. That's the incurred but not reported. That's that outstanding liability or lag to the claims, if you will. Through the month of January, the IBNR is $1.25 million. Any questions?
Any questions for Nate? All right, thank you. Next is item 6.5, a report on the City of Sparks Pharmacy Plan performance for the fourth quarter of 2025, presented by Vital One. Jennifer? So you're going to be right down here.
Good morning. For the record, Jennifer Salas with Vital One. And Derek, did you want to introduce yourself as well? He's on the phone.
Yes, for the record, Derek Berkowitz, Clinical Account Executive at Vital One. Thank you.
Thank you, Derek. Today, we're going to be taking a look at how 2025 compared against 2024. And we're going to run through some key findings, numbers at a glance, and then we'll have a clinical overview. Overall, the plan per member per month came in at $244.63, which represents a 22.9% trend. This is driven by specialty plan per member per month trend of 39.8% and traditional plan per member per month trend of 1%. Just want to remind you all that traditional drugs are everything that's outside of specialty, and you're going to hear a lot of today about specialty and traditional and the comparison between the two. Excuse me. Total plan cost for 2025 came in about $4.7 million compared to 2024, where we came in at $4 million. That expresses an 18.2 change in trend. Some of our key findings and observations: the GLP-1 RX count percent change is 24.3%, with a total of 292 claims in 2025. There are 46 utilizers in this class, increasing from previous period of 38. Our main cost drivers in this class are Mounjaro and Ozempic. From a traditional perspective, traditional trend is driven by diabetes and blood modifiers. Traditional drugs account for 35.9% of overall plan cost and 98.2% of claims submitted. Specialty trend is driven by hereditary angioedema and cystic fibrosis. Specialty therapies account for 64% of overall spend and 1.8% of claims submitted. Plan cost per member per month trend is 22.9%. The current plan per member per month is $244.63. The trend represents a 12.6 difference compared to our benchmark. The average plan cost per script is $342.32. The average plan cost per script is greater than a previous year by 21.4%, which is $147.65 greater than our benchmark. Specialty contributed 64% of plan cost. This represents a change of 7.7% compared to 2024 and is 18% greater than our benchmark.
I have a quick question on that slide. You indicated that there's, for the plan cost per member per month, it's a 12.6% difference compared to the benchmark. Are we 12% more expensive than the benchmark, or what does that mean exactly?
That is correct.
Okay.
Generic dispense rate came in at 83%. We like to see that at 85% or higher, so we'll continue to monitor that. The RX count per member per month trend came in at 1.3%, and the average member cost share is 5.3%. This represents a 2.3 change from 2024, and the trend is 7.7% less than our benchmark. Plan cost per member per month trend, as we said, came in at 22.9%. This is 12.6% greater than our benchmark. And we're going to break it down here and take a look at the difference between specialty and traditional. So for specialty, we'll see in 2024 that the plan cost per member per month came in at $112.08 compared to 2025, where we came in at $156.74. This expresses a 39.8% change. From a traditional perspective, in 2024, the plan cost per member per month trend came in at $86.90 compared to 2025 of $87.89. And then taking a look at traditional brand versus generic. In 2024, we came in at $67.99 for brand. 2025, we came in at $67.98. So we're not seeing a whole lot of change there. When it comes to generics, 2024, we came in at $18.90 and $19.92 for 2025, which gives us a 5.4% change. Average cost per script bill came in at $342.32. This is 21% greater than 2024 and also $147.65 greater than our benchmark. And there again, you can see the comparisons between 2024 and 25 with the same format that I went through on the previous screen. Specialty came in at 64.1% of plan cost. This is 7.7% greater than 2024 and also 18% greater than our benchmark. In 2024, we had 233 specialty claims submitted, and in 2025, we had 252. This expresses an 8.2% change. Member cost share is coming in at 5.3%. This is 2.3% greater than 2024 and 7.7% less than our benchmark. One thing I failed to call out when we're looking at the benchmarks in these slides, the blue is our benchmark and then the yellow is the city of Sparks. So I'll give you just a moment to take in that slide. Now we're going to go into our clinical overview and Derek will take over.
Thank you, Jennifer. So here's a big look from our clinical savings scorecard, and I'm going to try to give a little bit of color to the slides as well as I go here. Essentially, starting in the upper left corner, looking at our top traditional disease states, diabetes, blood modifiers, and cardiovascular. Really the only recent change here was the cardiovascular now in at the top three. However, cardiovascular, I'm thinking blood pressure medications mostly, was still actually down about 11% year over year. So the traditional was pretty flat overall, but we'll get a better picture kind of going forward. Essentially that class replaced asthma, allergy, and cold from our Q3 results. However, if you think asthma, allergy, cold, sometimes that spend can be a bit more variable depending on the season. So it kind of makes sense that maybe it got replaced. Diabetes continues to be that major cost driver there. Definitely aligning with our book of business. We'll see that in the trends in a bit. With the blood modifiers at number 2, that's a little higher compared to maybe our book of business, but really just often dependent on your member population. Those are typically the blood thinner medications. You're thinking stroke prevention. Makes sense that and then cardiovascular 2 and 3 kind of tied together, often maybe 1 and 1, if you have your blood pressure medications, you're trying to prevent stroke prevention with the blood thinners, et cetera. Top specialty disease states were hereditary angioedema, cystic fibrosis, and chronic inflammatory. Really, those are steady with the top 3 disease states not changing since we've last spoken. The naming, though, might just appear a little different. We updated, it used to be called complement inhibitors, but really that was more of a mechanism of action. And so we updated that to the disease itself, so hereditary angioedema, which hopefully is just a little bit more clear. Just remember that's the blood disorder and the high cost utilizer where it's one specific drug really driving that cost. But we'll take a peek at that. Essentially, specialty accounts for a little over $3 million in spend, and at 64% of your overall cost. That is higher than typically what we see at about 45 to 50% for the book of business. However, when you have that high cost hereditary angioedema, as well as a couple cystic fibrosis utilizers popping in that aren't necessarily typical for a group of this size, that can really drive up that specialty spend pretty quickly. And I know we've talked about it previously, but just remember too, we saw that the cystic fibrosis spend was kind of bumped up with one of those utilizers having some old claims needing to be reprocessed at the beginning of the year. So really, no change in the top three. However, over year, we did see that specialty spend climb quite a bit. On the positive end of things, if you kind of slide over, you see the estimated savings from the Managed Copay Solutions program. That's really where you're seeing some of the savings on the specialty side. So with that increase in specialty spend, you see some additional savings via this program where, essentially we're taking advantage of the available manufacturer assistance dollars to reduce copays and then plan spend overall. So remember, this was initiated in 2025. So essentially it's all new savings to the plan. I think we mentioned it previously, but it's just important that just to not overlook that the high cost CF utilizer wasn't even there on the spend back when we were considering initiating it. So we really did see some even more savings than maybe we had presumed. So that was a positive in that respect. Opioids, there were 69 members who used at least one opioid. Quarter 4, 2025, just one member using high dose, high risk. That's pretty typical. You might see one pop in there, but really looked good. I think just remember the goal essentially of we have a question?
No, we're good.
Sorry. I just want to mention we have that Vital One opioid management program that's always kind of happening essentially in the background at the point of sale. Really just the goal is to maximize member safety, follow prescribing guidelines. If there's anything that pops up, typically the pharmacist would have to either override it or reach out, at certain levels would actually have to reach out to the provider. So that's just always happening in the background, improving patient safety, getting that additional opioid oversight. Adherence. So I will never stop pounding the table when I see your adherence numbers. So just seriously, as a group, people be proud of the fact that we're seeing 91.6 to 94.9% in our targeted therapies. It's really impressive because, I think I'd mentioned, just as a clinician, it's great to see because unless you're taking your medications as desired, we're not going to really see those long-term outcomes, getting the medical savings on the other side. So we did see more of a nominal savings with our discount dynamic discounts program. I did put that on here, but just remember that's a free program where the manufacturers are kind of helping support adherence by dropping copays. If you remain adherent on certain brand medications, typically it's diabetes medications in this class, but just remember it's free of charge to the plan. And then last on this slide was the Better Choices program for cost avoidance, some significant savings at about $165,000 in savings. Those are those high cost medications with low clinical value. Really just apples to apples clinical comparison. And it's layered on top essentially as a formulary add-on, so it's no cost to the plan. And then when you think about it from like a member perspective, those therapeutic alternatives are listed on the claim when it's denied. So often the pharmacist actually even takes care of it right at the point of sale. So about 291, almost 300,000 in savings. I did also allude to, I kind of talked about we had implemented the Care Improvement Program Plus for 2025. So the savings, we're going to get those savings available probably early quarter 2. So still awaiting the results of the program, but I'm pretty excited to hopefully see the benefits of that to the plan, going forward. As a reminder, that's our pharmacist-led clinical outreach program. It's going out to providers essentially, and essentially we're using targeted interventions. So hopefully you see the greatest impact, reduce complications, improve outcomes, and potentially lower overall plan costs as well. Any questions before I, skip to our trend slide? All right. So going to the summary of the therapeutic classes, this is also, a pretty important slide. I think this really gets to look, you can see that, the client versus the benchmark, client being in the orange, benchmark being in the blue. Although we mentioned diabetes as that clear cost driver in the traditional classes, the PMPM trend still remained at about, 0 to 1%, which is great. The city remains under the book of business. yet also did not see those low to moderate, increases in trends that other plans have seen. The book of business was seeing about 7 to 8% in trend there. And really, when looking at the overall picture of the traditional side on the left, it looks pretty great with, 4 out of the top 5 classes actually had negative trend, which is phenomenal. The one class that kind of stood out to me in particular was this pain and spasm class at essentially number 5, kind of at the low end of your top 5. It actually saw a negative trend, especially compared to the book of business. We've really seen some growth. That's what we call the migraine class. So I wouldn't be shocked if we do see some growth kind of going forward in that class. But, sometimes it just depends on your member population. And, if folks aren't necessarily taking some of those high cost drugs, hey, we're happy to see some, some lower costs compared to the benchmark. Now, specialty, that's going to be, on our right side, really, this is where you see that hereditary angioedema, compared to the book of business. It's a massive spend. It's a rare disease. And I think from a positive perspective, at least the trend, isn't, continuing to skyrocket more. It's remaining more consistent now kind of going forward. The cystic fibrosis would be the one in particular that I kind of alluded to earlier with that big, we see that massive increase in PMPM trend. Both of these disease states, typically they're more rare. And so if you get a utilizer or 2 that pop up, it's going to, create a big amount of spend. But that PMPM trend, that is going to go down. It should hopefully get cut in about half. We'll actually see it on the next slide because essentially one of these medications is not on the plan anymore. The member was switched to an alternative therapy and they're going to be on that going forward. So I think, come Q1, it's going to look like we had a big decrease in trend, but, so I'm going to take that with a grain of salt once we see that too. But just as a reminder, it's not going to keep going up. It should go down, cut in about half. But still expensive when you have a high cost utilizer on plan. The chronic inflammatory disease, on the other hand, which is typically our number 1 cost for most for our book of business, is still low and actually saw a negative PMPM trend, about 18%. So we saw that previously, but that is very a positive to see that go down and still still continuing. Anytime you see an NA, remember that's that orphan drug at number 4. That just means new spend. And I know we talked about it previously, but that was that Atrophy orphan drug. Orphan drug essentially means it's a rare disease. Anything less than 10,000 people worldwide, essentially. Very small population, just adds to that same narrative that we've kind of been talking. Just a very unique specialty spend, for the city in regards to just a couple members driving up that cost. We'll take a peek here kind of at the breakout slides and kind of see a little bit closer for traditional and specialty. All right, so for traditional, here's where you get a really good overall picture of the traditional side. Remember, kind of Jennifer alluded to, think more of your standard medications. You're going to get them at your local pharmacy. Spend has been very steady, only about 1.1% increase in trend year over year. I know we could kind of see it coming when you look at like the top 5 drugs, but we kind of talked about Mounjaro at number 1 has taken over the slot for Ozempic. It's actually a good sign from a clinical perspective because it's actually more efficacious. I don't necessarily see Ozempic going away necessarily. However, we've seen it kind of trend flat, if not reduce a little bit. From a clinical standpoint, I've heard from, my diabetes experts that I've been chatting with, essentially, sometimes we still do see that Ozempic, maybe they don't want all of the weight loss that comes with the Mounjaro, but still has good A1C reduction. And those are two of the biggest, GLP-1s when you're talking GLP-1 therapies, and they're really dominating the space still to this point. But even the oral Jardiance still has its place as well. The other 2 in your top 5 are both blood modifiers. We kind of alluded to that being in the top 3. But Eliquis and Xarelto, if your blood thinning medication, just know all of these medications do have clinical PA. So for example, with Mounjaro and Ozempic, we're ensuring that these products are being used for their appropriate diagnosis. For those 2, for example, you need to try and fail an oral therapy think metformin being your most common, kind of oral generic, before you're being able to be moved to these higher cost therapies, as seen and mirrored in the clinical guidelines. All right, and then speaking to the specialty breakout slide here, you really can see there was that big increase, 39.8% PMPM. There was just quite a bit of increase in utilization, so new prescriptions, went up. I think we saw like 230 to 250, but then really those added claims for the CF member that I talked about, that you can see right here at number 2 for your high cost drug. That's that Kalydeco, and that is completely gone. So that is off the plan. And so that 17 PMPM is going to be gone as of Q1. Essentially that was moved over to your number 3 product, Alyftrek, which was the newer agent, on the market. Cinryze, that's your number 1. That's the HAE drug, clear cut cost driver. However, at least the PMPM, like I mentioned, is no longer skyrocketing. Essentially, we're just hoping to see this save money in the long run, keeping that member out of the hospital, preventing, expensive ER hospitalization visits. So it is certainly a high cost member. It's a rare drug, but really just hopefully preventing costs, down the line. Atribie, we kind of talked about that rare heart condition medication at number 4 for the orphan drug. And Lynparza is still in there for the oncology medication. Oncology did increase a little bit. A little bit at 30%. I mean, that's still a big increase, but, partially that was because this member was just on there for the full plan year. So that should stabilize, assuming we don't see a big change in drug mix. It's hard to predict oncology utilization as that can, as that can really change. It's depending on who gets a diagnosis or if you come off a med. Typically you stay on these meds until progression of a cancer or maybe side effects lead you to stopping therapy. The chronic inflammatory, the one thing I will mention here, on a positive, kind of ending, you're seeing the negative, PMPM trend that at Humira utilization with the transition over to biosimilars. There was only one member on Humira, but they successfully transitioned to the biosimilar for Humira, so that was a low-cost drug. If you hear about it out in the market, they talk about Stelara as the next big transition to biosimilar. However, when I looked at it, it does not look like there is any utilization on the plan, so we shouldn't be hearing any transition on that. However, positive would be that if any new utilization does appear, they would go right to that biosimilar. So I know I went over quite a bit to try to keep it more high level, but any questions in particular for me today?
Any questions? No, thank you.
Thank you. That is
Thanks, team.
Next item is 6.6, the report on the City of Sparks Group Health Plan performance provided by our third-party administrator, UMR. Russ, are you on the phone?
Yes, I am.
Give us just a moment to bring up your PowerPoint. Okay, we're ready, Russ.
Okay, Russ Garrett with UMR. I was just going to go over claims processed from January 1st through all of February. Total number of claims, 7,558. Of that, 5,493 are medical claims, 1,533 are pharmacy claims, and 531 dental claims. So far, you've paid we'll almost call it 1.7 million in medical claims, 134,000 in dental claims, and about 340 in RX claims. Total, roughly $2.1 million. If we break that down by a per member per month perspective, medical's coming in at $530, which is considerably higher than what it was last year, but it is a small sample size. And RX is at about $208. Total all in between medical and RX, $739 per member per month, in comparison to the book of business average for all of UMR, which doesn't take into almost I think is 9 million total members. City of Sparks is roughly about $200 per member per month more when we're looking at both medical and pharmacy. So far, we've denied 139 claims, and we've gone through what those denials usually are, duplicative claims, looking for other insurance, etc. As of right now, we have 104 claims that are over 30 days old. Those are usually high dollar claims that have to go through a different department and be audited prior to release. 105 of those claims are in between 10 and 29 days. 435 claims are at 10 days or less. We've had 88 ER visits contributing to about $330,000. If you look at a per visit from an ER perspective, that's roughly $3,700 per visit. 135 urgent care visits at roughly $10,000. And then if it's per visit, roughly $76, which is considerably lower than what we see on the book of business. Overall, in-network utilization is at 99.3%, and your savings with the networks is at 62.4%. So far, year to date, we have met all of our financial and procedural payment accuracy performance guarantees. And then lastly, and I'm not sure how it pulls up on the slides there, but for the number of calls, we've had 635 calls. 90 of those are from members, 33 are from dependents, 500 are from providers, and then ones that we just can't classify as 12. And that is all I had for today.
And any questions for Russ? Leanne?
Leanne, OE3. I don't know if this is the right part of the meeting to ask it, but I'm trying to get help for a member. Not disclosing like too much information, but essentially they have a dependent who they're working with a provider that's out of network, and every time they call and try to get the provider to have an SCA, single case agreement, they basically start the process over every time they call in. So they're trying to find a way to get the provider and their dependent on the plan, but every time they call, they just get the same runaround back and forth. So is there a way we can help them and maybe give them a single point of contact to work with?
Please share that information with HR. They'll send it over to me. I'll get it to somebody that maybe we can eliminate the middleman and see what we can do there.
Thank you.
Any other questions for Russ? All right, just a reminder, the UMR rep is here for her monthly visit today. Thanks, Russ.
Thank you.
All right, the next item is 6.7, report on health insurance alternatives presented by LP Insurance. And before they speak, I have a few things to say as kind of an introduction. During labor negotiations, as you know, we used a total compensation analysis, which included wages, city benefits, health insurance, PERS contributions, all of that in your total compensation. We currently offer a very rich and robust health care plan. But what we heard from employees is they would like alternatives. They'd like other options. Right now, we just have one plan. Some employees would consider a less robust plan. Maybe they don't use health insurance as often, which could potentially mean more money in their pocket. It's basically a finite pot of money, and the presentation is going to discuss different ways to divide that pot of money. Today, they're going to provide some options, so I wanted to discuss procedurally how this will work. The voting members on the dais are able to ask questions related to the options in the presentation. Non-voting members and public are able to make public comment during the public comment section at the end of the meeting. This public comment section, just like city council, is not a dialogue, so we're not going to be responding to questions, but you can make your public comment and it will be in the record. And today's presentation is not a voting item. Now, what we do ask you to do is on the top of the agenda is the list of representatives for the group healthcare committee and their alternatives. We ask you, after this meeting, I feel like this is going to be a lot of information provided, and you're definitely going to have some questions. So please send those questions to your representatives, and then I'll ask those reps to give any questions, kind of summarize them to me by April 6th, and then we can address those questions at the next meeting, which is scheduled for May 21st. Right now, our thought, let's see how it goes with all of these questions, but is that the May 21st meeting, we could have a workshop and kind of dive deeper into some of these options or other alternatives that you're considering, as a group. And we can discuss that. Now, if we're going to make changes for January of 2027, time is of the essence. So after the May 21st meeting, we're looking at holding a special meeting between the May and July meeting, June, where we could actually vote on potential changes for the plan offering. So there's lots of different ways that this could be looked at. These are some suggestions. We're open for others, but we heard you. We heard you say, I want more than just this one plan as an option for our healthcare. So here we go.
Great, thank you for that. Nate Kerr with LP Insurance for the record. Just to kind of piggyback off some of Shauna's comments, understanding that benefits play a very critical role in the attraction and retention of a high-quality workforce. At the same time, the rising healthcare costs that is consistent is forcing some difficult decisions, right? Some difficult trade-offs, if you will. That total comp bucket, that definitive pie, if you will, that Shauna mentioned. So with that in mind, the purpose of today's presentation is to explore some options to help us not only maintain a competitive benefit offering while keeping long-term stability in mind, but modernizing the health plan, if you will. We're going to go over some benchmarking for some local entities that we kind of used as a backstop starting point that we think is good in that regard. So just some level setting points here. The current plan structure is a partially self-insured health plan. Say partially because, as many of you know, we do purchase some insurance protection for the high dollar claims, known as stop loss. We have one plan option, and the city pays 100% for employee and 75% for dependent. Very traditional, old school, if you will, type of plan offering. It does have a rich plan design, and that has been the case in a fairly stable manner for quite some time. Comment there that the deductible levels have actually been as is since 2007. So it's been quite a while since there's been any significant updates or changes to the benefit offering. Again, just some level setting, looking back at the performance snapshot for calendar year 2025. Total net plan cost, that would be the cost after we receive any rebates or stop loss reimbursements, all in was $13.5 million. So benefits obviously is a substantial line item for the city. The year-over-year increase in net cost was approximately 13%. The actual cost was a little lower than that, but because we had a drop in enrollment, that offsets that number a little, right? That we went over in our report. As Vital One mentioned, specialty prescription drug trend is running pretty hot, 22, 23%. And RX spend for the city in particular makes up about 33% of total spend for your group health plan. So prescription drugs is a substantial component from a cost perspective of the city's benefit offering. And we'll come back to some ideas and concepts in that space. We looked at the 3-year trend for the city, understanding that year over year, we're going to have some volatility with a plan our size. The actual 3-year trend for the city has been about 11%, which is in line with what we would see regionally and even nationally, right? Regional trend is running around 10%. So good news in that regard that we're not well above that. And just a reminder that retirees make up about 21% of our total plan enrollment, although that is down a little year over year. And again, we'll get into some topics related to that here later in the presentation. Market dynamics, these are probably go without saying and have been touched on in one form or another, but obviously specialty drug costs, utilization patterns, provider costs, some of these chronic disease prevalences that are emerging are definitely driving a lot of the costs that we're having to deal with. GLP-1s, which traditionally have been used to treat diabetes, is now an expanding conversation, if you will, now that we have additional indications in which some of these drugs are emerging into. So that'll be a developing, ongoing market dialogue and dynamic as we get into this. And then adding choice as a component to the benefit offering. I think that is absolutely a trend and something that a vast majority of employers are gaining a lot of energy around, bringing the choice component into the health insurance and benefits offering. Okay, in looking at putting together some potential plan designs to help modernize, if you will, or provide some options for the city to consider, we thought. Good? Yeah. All right. We thought a good place to start was maybe with some local benchmarks. What is the city of Reno doing? What is Washoe County doing? Washoe School District's a little bit different of an animal, but we thought these two actually fit fairly well. So just to give an idea of how the city's of Sparks plan compares to some of these other local entities. And again, this is high level, right? We tried to touch on the highlights of where we think most of the benefit criteria fall within. We put some reds and blues on here just for the ease on eyes. Anything in red is what we feel is a reduction in benefits compared to the city of Sparks. Anything in blue is what we feel is potentially a benefit enhancement compared to the city of Sparks. So you can see there that depending upon what category you look within, there are some reds and blues. Overall, City of Sparks plan does compare very well, if not the richest in some of the local government benefit offerings from a benefit richness. Some things to point out: prescription drugs, prescription drug categories down there at the bottom. You'll see that the City of Sparks has maintained and still maintains a very, very, very rich prescription drug benefit offering. We're going to come back, have some comments about that later in the presentation, but you can see that the city and the county, their prescription drug plan is not nearly as rich as the city of Sparks. And then just put some criteria down at the bottom there just to indicate and point out the fact that the county and the Reno are substantially larger plans, right? That's the approximate member count down at the bottom there. Just keep that in mind. I know we mention all the time when we're up here, we talk about volatility and some peaks and valleys and how we see the cost performance. The larger you are, the less that plays a part. From a contribution perspective, City of Sparks, very much in line at the upper end, if you will, of what their contribution structure is. Understanding that Reno and Washoe pay for a little bit less for dependents, but same for employees. So with those benchmarks in mind, we put together what we felt might be some good plan options. As a starting point, this is that time of year every year when we look at the current health plan and we provide a projection for what we think the costs are going to be for the upcoming year. And of course, apply that to the revenue side of the house, i.e. setting our rates. We've gone through that exercise that we go through every year. That is the two columns that you're looking at here. I know it says current plan. The first one is the cost reality of today. The second one is what we're projecting for the upcoming year. And as you can see, we're projecting no increase, a flat for the current benefit offering. So with that in mind, what are some additional plan options that maybe we could add into that from a choice perspective? Again, using our benchmarks as kind of a starting point, we put together these two options. Option one is a plan that looks very similar to the City of Reno. Deductible is just a slightly higher, but very similar to City of Reno. And you can see that from a plan value perspective, don't get too caught up in the actual dollar amounts here. We have that just for comparative analysis to see the value of the plans. It's about 9% less than the City of Sparks plan. And again, we'll get into a little bit later into the presentation about how that translates to employee costs, city costs, choice and flexibility. The second option here is an HSA option. QHDHP stands for Qualified High Deductible Health Plan. This is an HSA compatible plan. As you may have noticed in the benchmark plans, most all other local government entities in the area do offer an HSA type plan in their benefit offering. So we thought that would be appropriate to consider. And you can see, obviously, given that the deductibles are substantially higher, right? It's one of the criteria of that type of a plan. The cost or the value of the plan is significantly lower. Okay, so before we get into some of the details, understanding that the city hasn't offered an HSA option, we thought maybe it might be good to start with just some basic HSA high-level education. What is an HSA? It's important to keep in mind that the HSA component is a separate component from the insurance plan, right? We just looked at the insurance plan on the prior slide, what the benefits are, the deductibles are, the out-of-pockets are. The HSA is an individually owned bank account that layers on top of that plan, right? It's a financial vehicle that allows you some flexibility in potentially how you engage in the consumer process from a healthcare perspective. There are some catches to it. It has to be paired. This is IRS requirements, has to be paired with a certain type of health plan. That is the Qualified High Deductible Health Plan, hence the naming. Any contributions that are made into this HSA account, which by the way can be made by employees, it can be made by the employer, a combination of both. Any contributions that go into that personally owned bank account is tax-free. And any distributions or anytime you pull out funds and use them for qualified medical, dental, and vision expenses, those are also tax-free. So there is definitely some upside from a taxability perspective. The IRS does set some limits given that the tax favoredness. $4,400 for an individual is the maximum that can be funded into an HSA, at least for 2026. So a lot of times that indexes every year. If you're enrolled with dependents, then your limit is $8,750. Some advantages to the HSA. This is one of the reasons why HSAs have taken off quite a bit, right? Why a lot of employers are offering these as part of their benefit offering. The contributions, the funding that goes into the HSA are not subject to the IRS irrevocable rules. And what I mean by that is I think most of us or many of us here are familiar with FSA, Flexible Spending Account. It's current benefit, current vehicle that the city uses. That comes with an irrevocable rule, right? You have to make your election at the beginning of the year, how much is going to come out of your paycheck every month, and then you're locked into that for 12 months, unless you have a qualified life-changing event, birth, death, divorce, marriage, adoption, so on and so forth. HSA does not come with that type of restriction. It allows you some flexibility. If you want to start out with $100 a month out of my paycheck and next month go to $50 or go to $300, it allows for that some of that flexibility. The accounts can grow from an investment perspective. These are technically bank accounts, right? So depending upon the financial institution, there are some potential investment options, similar to an IRA. Permanent access and portability, this is a personally owned account. So if you leave, it goes with you, right? There's no use it or lose it. That's another point there at the bottom. Any funds you don't use at the end of the year, just roll over the next year, okay? And there's no limit of how much funding you can have in that account in total, right? There's an amount that you can put in on an annual basis, but the overall balance of the account has no limit. And it's fully portable. You leave, it goes with you. Once it's in your account, you own those funds as an individual, regardless of your situation into the future, okay? got to be some catches to it. The IRS set some rules. So who's eligible for an HSA? Well, as we mentioned before, you have to be enrolled in a certain type of plan that the IRS sets. That's the qualified high deductible health plan. And you cannot be participating in any other type of health insurance plan that does not also meet those qualified high deductible health plan rules. Very common situation is maybe you're covered as a spouse on your spouse's plan, right? That may be a non-qualified high deductible health plan. That would be a disqualifying event for you to set up an HSA and fund money into. That includes Medicare, right? Medicare and FSA. You can't have an FSA and an HSA together, okay? And you cannot be claimed as a dependent on another person's tax return for obvious reasons. A little double dipping there from a tax perspective. There is a lot of things that can be learned, known about HSA. Wanted to keep it high level today in the interest of time. So I provided some resources here, some resources for reference. These are very user-friendly documents that are easy to search and pull up that give a lot of detailed information on HSAs and these type of tax favored accounts. You know, what is a qualified medical expense? What is a qualified vision expense? Hey, does chiropractics qualify? All these types of questions can be addressed in some of these resources. So that's why I provided those. Okay, our benchmark plans that we talked about earlier, you'll recall option 1 and option 2 as they're labeled. Of course, moving forward, if the city ends up deciding they want to offer, we can pick whatever name you want, but moving for the interest of this presentation, option 1 and option 2 are the 2 plans that we looked at. This is the breakout of the cost of those options by tier. And this is for active employees, right? Because contributions, we're talking contributions, contribution meaning how much does the city pay, how much does the employee pay? That only applies to active employees, right? Retirees are in a different environment from a contribution perspective. So in this particular scenario, what we are proposing is offering 3 plans. You would offer the current plan as it is today. That's the one highlighted in blue there. And the current contribution structure, the same cost structure as it exists today. So that is exactly what is intact now. However, bringing choice into the equation, option 1 and option 2, if you decide that maybe you don't need a plan that rich, and or maybe you carry dependents or a family, so the cost is very difficult, it's substantial to pay on a monthly basis. Or maybe you're a retiree who has to pick up the total cost of the coverage. All of these reasons, option 1 may be a more favorable cost option. Yes, the benefits are a little bit skinnier, at least in some categories, as we looked at in the earlier slides, but it provides some choice that you don't have today. And then option 2, with that same idea and concept in mind, additional choice for a different type of plan based on how you utilize healthcare, understanding the HSA component that we went over, right? The idea being here on the option 2 that some of these red numbers that we're seeing, those funds would be allocated or contributed into an HSA account. So you have a bit of a fund that's building up on the side if and when you need to go in and get your dental implant or a new pair of glasses or whatever, medical bills. Added some bullet points down there at the bottom. The HSA, you can see there, all I did was I just took that far right column, the red numbers at least, and annualized them to give you an idea of what that account potentially would look like at the end of the year. Okay, HSAs, I guess probably should have mentioned in the HSA education slide, a little bit different than FSA in that you don't get the full access to the total annual amount day one, right? That is the case for FSA. That is not the case for HSA. It is simply a savings account. You can spend what you have in there on that particular point in time.
Before we move on, any questions on this? No? Okay.
Okay, understanding there's a few ways to look at contributions. How are we divvying up the cost? How are we going about funding this stuff? We looked at another option. This is a common approach in the benefits industry, known as a fixed dollar. Sometimes it gets caught up in some of the criteria of cafeteria type plans, right? Where you have the flexibility to go out and select whatever benefit offering that fits you best with a set funding amount to start, right? So the city would say, hey, here you go. Here's a pot of money. Go spend it however you want. Pick whatever plan you want. 1880, I know is a strange number. Where that number came from is that's actually the number that the city contributed, is contributing currently on a per employee per month basis, right? So that's all in, employees, dependents, childcare, every tier, based on that 100% employee, 75% dependent contribution model. This is the most simplistic way to go about that, just PPM composite, 1880. And as you can see, it does kind of translate a little wonky in some of these tiers because of some of these large swings, given that you're only doing it on a PEPM basis and not by tier. But again, same concept, same idea here. Gives the employee more choice, more flexibility to decide how they want to spend the monies allocated for their benefits. Right? This is the same concept, but smoothing it out a little, right? Instead of just saying 1880 per employee per month, let's break it out by tier, understanding that every tier comes with different costs, right? That at the end of the day will end up being on a composite basis very close to that 1880 overall, okay? So it's just a different way to divvy it up. So we've broken up the funding by tier. The $1,100 up at the top there, that's for employee only. $1,800 for employee spouse, children, $1,700 and $2,500 for family. Okay, and again, you can see how that plays out. Very much could not only hit on choice, providing some choice in how you spend your funds, but depending upon your needs, there are some good options there for potential savings or benefit richness.
Any questions so far? And just FYI, I'll send this PowerPoint out to the entire city afterwards.
Some additional considerations as we engaged the city through this process and discussion and dialogue. One thing that was brought to committee before was speech therapy, the caps for speech therapy. We were asked to address the potential of maybe removing that. We did go back, look at the claims, and did what we felt was a conservative projection that it would be roughly 2 to 4%, if you will, of the speech therapy spent. So on average, over the last 2 years, spent about $10,000 annually for speech therapy. If you were to completely remove all limits there, $2,000 to $4,000 increase potential. Not substantial. However, the recommended approach, or what we would recommend, which is very common in the industry, is if you do remove that cap, just set the medical necessity threshold at 25, which is what you do for all of your other therapies, right? Physical, occupational, so on and so forth. So there wouldn't be a limit, there would just be a review at 25, after 25 visits. And then Vital One did a good job going through overall, so I won't go through each of these line by line, but the idea here being that Vital One does offer a variety of cost containment programs, and the city actually has adopted a few of those over the last couple cycles, right? Which has equated to some savings, all good things. I point that out because at this point, really the only two bang for buck, or the real meat left on the bone from a prescription drug cost consideration perspective, is in that benefit structure, right? Where are the copays at? Is there a deductible? Do we maybe make specialty drugs a little bit more expensive? So, in how you set that plan design. And then formulary. Do we want to expand, constrict, put in some additional cost control or edits within that formulary? Formulary being the list of drugs that's provided, that's available. Questions?
Leanne?
Leanne, OE3 for the record. If you go back to the slides where you're showing the HSA benefit with the numbers in red, based off of like what you presented, you guys are saying like if our employer portion stays consistent, that money isn't necessarily money back to the employee, but money going into an HSA account?
Go to slide 7, I think is probably the one you want. This one?
Yeah, I guess even in the slides following this one too. So like the employee costs, seeing all those like negative numbers.
So the idea and the concept is the cost of that plan, right? Because it's a skinnier plan. The cost of that plan is lower. So understanding that the city is still contributing the same funding levels that they are for the current plan that exceed the cost of the plan, there is going to be money left over. And the idea and concept, at least in the HSA space in particular, is set that money into an HSA account. You are taking on a higher deductible, right? And at the end of the day, that is truly is savings over what you're paying today, right? So it's no additional cost to the employee. Now, of course, if the employee said, I want to add another $50 on top of that out of my paycheck, you could do that. You have the flexibility to do that.
And Nate, clarifying meaning just for option 2, because you can't put in, remember, I had a question about this. You can't put into an HSA for option 1.
Yes,
So you're seeing that negative number for option 1, that would function differently.
correct.
And it, just for the high deductible plan where you see those negative numbers, that money could go into an HSA account if that's how the group wanted to create the plan. The option 1, I want to go back to Shauna with how that could look like.
I think I can address this. So let me dive in a little bit deeper into this slide. The current plan is what we have now. And you would have the choice, if that works for you, you could keep it. But if you notice the employee cost, the EE cost for employee and family is $437. This is what's coming right out of your check. For option 1, it's $190. So you're already seeing a savings in your paycheck, more money in your check if you choose option 1. Yes, your deductibles are higher. Your out-of-pocket costs could be higher. It depends on your utilization for your particular situation for your family, if that's the right choice for you. Option 2 for a family, there is basically no cost per month. It's $2. In the employee and spouse, employee and children, employee only, that money, the additional funds that go into an HSA are very flexible for utilization. You can use that to pay your costs because you do have a higher deductible and a higher out-of-pocket cost. You have this fund to pay for those things. Very handy also if you're not a high utilizer of the health insurance. When you go back to option 1, and where there's a $94 savings for employee only, there's lots of options for this. And the other thing that I want to mention before I get into the options of that is when we did our total compensation study, the city is paying $2,385 for employee and family across the board. If we changed to where that cost is lower, when we talked about the 1880 or the 25 or whatever those costs were for the family on the other slides, then that goes towards the total compensation at a lower rate. So I'll kind of give you an example. I plugged in just the 2385 family into the spreadsheet for the total comp, and then I plugged in 1880, and the average person would be, it's a 4% difference. So if you were at market for your position, and when you plug in 1880, now you're 4% below market, you would get the 4% pay increase to go up to market. So it's kind of a balancing act. Now, the other thing to note is we have to know that not everybody's going to switch over right away. This could take a few years for people to be more comfortable with a high deductible healthcare plan or some of these other options. And so we may not see savings immediately when we offer these other options. Reno, I believe, requires all new employees to go into the high deductible healthcare plan for the first 2 years.
County.
Oh, county, it's the county, okay, that requires that. So about the $94, there's alternatives. It could be that you have options for other things like life insurance or short-term disability, long-term disability with that money. It could be that it goes into an FSA. There's many options that would be discussed, considered. This just gives you more alternatives. And right off the bat, looking at this, especially if you're a family or a spouse, you're saving money each month by picking option 1 or option 2. Does that sort of answer your
Yeah.
question?
I guess I have a follow-up question to that too. For HSA, can you talk about like how that works upon retirement? So when somebody has that money and they retire, how can the funds then be used?
Sure. Yeah. Back to the statement I made before, which still holds true. Any funds that have gone into that account, because you've met the criteria, once they've gone into the account, you always have access to those, no matter what, forever. Okay, so even if you retire, you enroll in Medicare, you move to Oregon, you still have all the HSA funds available to spend. The catch would be is that, and this is not necessarily retirement, this is due to, remember the criteria. Let's say you are a retiree who enrolls in Medicare. Okay, so if your retiree enrolls in Medicare, well, Medicare is not a qualified high deductible health plan. And all that means is you can no longer put money in to your HSA. The money that's in there, you still have access to. You just can't put more money in. There are a variety of approaches that can be deployed that a lot of these other entities deploy for folks in that particular space, right? Otherwise, the retiree is saying, well, you're giving everyone X amount of funds, and then when I retire and enroll in Medicare, I just lose out on those funds. There are ways to continue to offer a similar type benefit, most commonly through what's called an HRA, health reimbursement arrangement. Works very similar to an HSA, but is compatible for retirees with Medicare. The other public entities in the area do deploy it that way.
And is it also accurate, Nate, that after a certain age, you can use it for anything?
I'm sorry?
Is it also accurate, Jessica, for the record, is it also accurate that after a certain age, the funds in your HSA can be used to pay anything, not just healthcare costs?
Yes. Yeah, I believe it's 65.
Five.
I think it's 65. Once you're 65, if you decide, hey, I want to take my wife to Hawaii and I've got this huge pile of money in my HSA, you can do that. You're just going to have to pay normal taxable income on it. Someone?
About this way.
Talk loud, this is a big kid.
Lloyd Barnes, LP Insurance for the record. Just for a little clarification there. So before you're 65, you can use those funds for any qualified medical expense, as Nate referred. They're always tax-free. After you're 65, similarly, you can always use those for any qualified medical expense tax-free. Before 65, you can use those funds for anything. You can go buy a big screen TV if you want, but you're going to have a penalty from the IRS and you're going to pay taxes. After 65, you can use them for anything you want. It's not medical and you only pay taxes, not the penalty.
And it could be used for dental for retirees, which
Correct.
Medicare doesn't
Dental and
cover.
vision.
Yeah.
Dental, vision, and premium, if potentially retirees, right, are having to pick up some of their cost.
Chris, do you have a question?
I do. Nate, Lloyd, correct me if I'm wrong, but are comparables for their high deductible plans deposit, like the city and the county deposit a certain amount every year towards the deductible in that HSA account, is right?
Correct. Yeah, that's the HSA funding down here at the bottom. To give you an idea, and that's right, that's just for employee only. They only have 2 tiers of contribution, employee only and those with dependents.
Okay.
Those are the 2 buckets on an annual basis.
Is that something that we would be doing with our own option as well?
That would be up,
Option 3, or is that something that would be up?
that
to
would
us?
be up to the city to decide.
We haven't delved into that yet,
Okay.
but that's the kind of feedback that I'm looking for to prepare for the next presentation.
Got it.
Yeah, and Chris, I think what you're seeing there is going to the slide around the difference where maybe go to the contribution slide, where Nate shared the information on, at the bottom there, on the potential annual funding. So the city and the county, when they did their exercise on this a few years ago, or whenever they did that, they had similar numbers and they determined that was the amount that they were going to contribute to their funding.
Gotcha.
So that's the methodology. So you raise the deductible, lower the benefits, it leaves a pot of money, then all the interested parties decide how that money gets spent.
Gotcha.
Rachel, SPPA. So if we decide to go with the three options, how easy would it be to go, so say you're on the current plan and you want to go to option one, would you be able to choose that at any point during the year? Are there specific times you'd be able to pick it, or?
No, that you cannot decide any time of year. You can't go, well, take option one for the first 2 months and then option two for the next month. And then IRS irrevocable rules that I talked about earlier apply in this scenario. So whatever you pick during open enrollment every year, right? Your one time a year, you get to decide what you want and who you want on your plan. Once you've made that selection, you're locked into that selection for that plan year, unless you have a qualifying life-changing event, right? Birth, death, divorce, marriage, so on and so forth. That applies to changing plans too. That also gets folded in there.
Any other questions at this point?
Sorry, Leanne, OE3. For HSA, are there certain providers that will take it and certain providers that won't take it?
So again, the HSA is just a bank account that lives on top of the insurance plan, right? The insurance plan is the same list of providers, no matter which option you pick. All the options use the United Choice Plus network for providers. So what plan you're on doesn't dictate what providers are available to you.
Be a different colored debit card
Okay,
from like your FSA card.
that makes sense. And then as far as like a high deductible plan, do we have examples of what the deductibles would look like? That was on.
Yeah, so there's option two right there, which is the corresponding contribution slide we were referencing, option two. So 2,600 individual deductible and 3,400 for family.
And those are like a standard set by the IRS?
The
to have
IRS
the
sets
HSA.
the floor. The IRS sets the minimum. It has to be at least as high. And these are actually right there at that floor
Okay.
to just barely qualify.
And then Chris Hartwig also, for the record, once, I assume that would be like any other insurance plan, once you hit your out-of-pocket maximum, then you're 100% covered on the high deductible plan, correct?
Yep. The functionality of the criteria is no different. Gotcha. Deductible is still deductible, it's just a different number. Out of pocket, still out of pocket, it's just a different number. The functionality of how those all work remains the same.
Lloyd Barnes with LP. Just one clarification there. Back to the requirement that the IRS places on those the qualified high deductible plans have to look a certain way. One thing that is important just to remember is prescription drugs have to live behind the deductible as well.
Okay.
So we're all used to paying a copay for prescription drugs. One thing that sometimes catches people off guard that they don't recognize is that everything has to be behind the deductible with the exception of preventative care. So preventative care can still live outside and be 100%. Deductibles, doctor's visits, all of that is subject to the deductible, and then whatever the benefit is built.
Very, very similar to your current plan, with the exception of the prescription drugs. That would be, and the parentheses D, by the way, just from a formatting perspective, anything that has a parentheses lowercase d means the deductible has to be met first, just for reference. You can see obviously on the HSA option, that's every section except preventive.
And that is an IRS requirement.
Correct.
That's a design requirement that we can't modify.
One more question, Leanne at We3. From a HSA, we can change the amount we're contributing to it monthly. From like a city feasibility standpoint, is that like a payroll function there? We're going to submit something to them. They have to change it. Like, what do the deadlines look like? And is that something that they're going to be able to keep up with if a lot of employees are wanting to change it?
It would go through payroll. If there was a portion that the city agreed upon would just go in if you were in that plan. If you were opting for additional, yes, it would have to go through payroll. And it could be changed throughout the year, unlike your FSA.
Yep, that is the flexibility. If any funds that you put in there, you can change. We would hope, for the sanity of HR and administrative purposes, that's not really frequent, but the option is there. That would be something for the city to decide on how flexible they want to be.
And then Shauna, one more question. I think you touched on it for the total comp studies, but just trying to understand that if we do change the options that are being used and how the comparables are used to determine like an employee's salaries, what does that look like changing employees' wages to match the benefit level that they would now enroll in? If that makes sense, or that calculation.
I think I know what you're asking. Let me know if this isn't what you're asking. So right now, the majority of the city employees are employee and family. And so we are using, and it's common when you're doing an analysis, using employee and family. And we're also using employee and family on all of our comparables. So we're saying the employee and family is X. Conceivably, if enough people switch from our current plan to something else, and the majority of the employees or the majority of a certain bargaining unit are now employee and family option 1 or employee and family option 2, which has either a 9% savings up there or a 15% savings, then we could utilize that as a comparable rather than employee and family in the current plan. But like I was saying earlier, it may take a few years to get to that because people are reluctant to change and they may not jump on right away. So if we still have the majority of the people in the current plan, then we would still use that current plan amount. However, they would still experience the savings to their paycheck because they're not paying the $437 a month. Does that make sense?
It does.
Okay.
Thank you.
Does that answer it?
Chris Cropworth for the record. Nate, can I have you go to page 7 again? I just want to highlight a couple things. I've been on and off of this committee for more than 20 years. So what I kind of want to highlight to people is Shauna states that the employee plus family is our max, but if you look at employee only, we're pretty close. So what I want to highlight for all of you is Nate has talked a couple times about the average employee cost is $1,880 a month. But if you look at the very first column under our current thing, someone with a family is getting a $1,000 benefit that someone without a family is not. So we are not equitable. We have never been equitable. This goes to healthy lifestyle stuff. He talked about emergency room stuff where 88 visits cost all of us nearly $400,000 versus several hundred visits cost us, I think it was 10 or 20,000. So there is things for you to think about of as bargaining unions, things like that. Does the city contribute $1,880 to you? Do they contribute $2,500 to each of your members? And depending on what you pick, you get money from the city into an HSA. So that is some of the consideration. But we, as a city, have never been equitable, meaning some employees are definitely receiving a better benefit out of the healthcare plan, and others are paying for that, if you will. So when you look at 211 employee plus family versus 173 employee only, the employee onlys are receiving less benefit. So I just want to highlight that in your discussions of I've never seen this needle move in 20 years. And that's maybe another lens to look at it, is the equity for your coworkers, if you're union people, for the entire membership of what's that number? At the end of the day, the city contributes roughly 13 million to this. Where do you want it to go?
How do you
Thank you.
want to divide that pot? Speaking of which, let's look at the other analysis. So this is one portion, offering 3 different plans, offering options. Another portion is how do we divide up that pot of money? The 1880 versus, a percentage versus the other numbers that you had, the, 1,100, 17, 18, and 25. There is another alternative, and that is we don't make any changes except we keep our current plan and we make some changes to the current plan, or even the current plan which we keep, we make changes to it. So then we have the current plan revised, option 1, option 2. These are some potential savings in the 2027 plan if we made some minor changes. For instance, the deductible of $200 has not changed, and it will be 20 years by the time this plan is changed. If we change those deductibles, if we make some minor changes, what does that look like for the plan? And if the overall plan has reduced costs, then that total compensation package is reduced for the city's portion, which could potentially end up putting more money in your pocket in the long run. So Nate can talk about a few options to consider. This could be completely separate from the previous discussion of the three options, or this could be part of that discussion of the three options. So, Nate.
Yep. Nate Kerr for the record. Yes, this is for many of you, it may be a familiar exercise, if you will, familiar exhibit. Each year when we do our plan projection, right? Hey, what do we think costs are going to look like next year? We usually provide options as well, in a, for lack of a better term, in kind of an a la carte fashion, if you will. Or we can look at some of these different categories and say, if we made some tweaks and adjustments here, what potentially would the impact be to the plan from a cost perspective? So there are a myriad of areas and benefits that you could change and amend. We try to stick to the ones that have the most bang for buck, if you will. And you'll notice as we go through this, which again is nothing new based on what we've done in past years, but you have to make some significant changes if you want significant savings, right? So this first section here is just the deductible and out-of-pocket, obviously two main criteria, right, that have a significant impact on the plan. These options are simply combinations we put together and essentially just bounced it off the current plan's cost. So if the plan would have had these benefit category last year, it would have equated to X on the right, if that makes sense. So you can see there, just for example, if you were to take the current deductible from $2,000, $4,000 to $3,000, $6,000, and the out-of-pocket from $1,200, whatever that is, $2,400 to $1,200, $1,500, then that would equate to roughly $75,000 savings to the plan. So on and so forth. Obviously, the farther you go down, the bigger the changes, the more savings. This office visits, emergency room, and urgent care benefits. The office visits there, as you know today, it's deductible coinsurance, right? Deductible then 80%. The addition of a $10 copay doesn't mean we remove the 80% or the deductible. It just means you add an additional $10 on top of that, just to clarify that. A lot of folks see copay and they think, well, that's all you pay. You just pay your copay and you're done. So no, it would be an additional copay on top of your current structure. Same thing with urgent care. Same thing with emergency room. I did put an asterisk there on the emergency room for the 100% benefit for ER coverages for accidents within 48 hours. I understand, because someone might say, hey, well, Nate, it's actually 100% if that's the point of the note there, the footnote. And then ambulatory surgical center, we just put that on there. That was something, it's got a little bit of history and background to it, but that benefit is 100%, no deductible, very rich, obviously. And the reasoning for that was due to some historical contracts that the city had access to that was going to be more favorable in an ambulatory surgical setting, same-day surgery type setting with certain providers. And therefore, the benefit structure was amended to help drive that as a mutual benefit. Those contracts have since gone out of existence. And so now we just ended up with a very rich benefit. That said, if we wanted to simply align it, just align it with all of the other benefits, deductible then 80%, comes out to about an $85,000 savings to the plan. And then last category here, pharmacy and dental. I think I mentioned on the pharmacy side, understanding that pharmacy makes up a very high percentage of every dollar the health plan spends. The only two main areas left to make an impact on the prescription drugs is the copay structure, and that's what we're talking about here, or the formulary. But you can see here, the first two, option 1, option 2, is leaving the copay structure the same and just adding in a deductible on top of prescription drugs. Option 3 is just changing the copays. Obviously, what is that? A little more than doubling, about doubling the copays. And you can see there the savings on the right. And dental, much smaller impact, obviously, unless you make some significant changes, but we put some additional deductible and out-of-pocket max options there, trying to, at least to the extent possible, preserve as much of the benefit as possible.
One thing to note is for this year, for July, we are estimating a 0% increase. Estimating, it's not finalized yet. 2027 could be a higher increase. 10% increases annually are not unusual. So some of these changes may not be a savings, it may just to keep it flat when we make these types of changes, so that increases are not experienced and we reduce some of these very rich benefits to a more manageable level to keep the costs down.
Nate, is option 3 on dental supposed to be 500 deductible? It shows 50.
I think you're right.
No,
Shows
the fund's
193.
different there, is lowering the maximum benefit by $1,000.
Oh, okay, thank you.
So yeah, it is $50 deductible, but the out-of-pocket max has gone down 30%. I'm sorry, maximum benefit.
Rachel, as PPA, so what we were talking about previously, we could choose to have all 3 options at the same time and the person would just choose. Would it be the same with this, or would it just be you pick one? Or you have the option of picking out of the 3?
The idea and concept behind these slides here is to give the committee some options for changes to the current plan. If you took the current plan and made these changes, we would project that type of savings. It's not a selection where by employee or, yeah.
Right.
As a
So-
committee, you would come together and decide, here's what we want to do. Here's the changes that we want to make.
Right. We could, of the 3 options, leave the current option exactly as it is now, and then offer the other 2, including the high deductible healthcare plan. Or the current option we have now has a few revisions. Maybe we increase the deductible or increase the copay for prescription drugs, and then still offer the other 2 options. So that's what the discussion is about, is for all of you to consider that, talk to the folks that you're representing, get their input. I'm going to send a summary out to everybody along with a link to the video and this PowerPoint so that they can provide you information, ask questions, and then we'll get together again and go over those.
Leanne, OE3, as far as deductibles work and like how other plans work, is it pretty common that it's always like deductibles for self and then self and family? Is there any like in between of that deductible wise 4 options or?
Absolute industry norm is that 2-tier structure, individual and then individual with 1 or more dependents, also known as family. I'm sure there's some flavors out there, and as a self-funded plan, you could really build it any way you want, but traditionally it's 2-tier. All of the other plans in the area are 2-tier. I don't know of any other in the area that do anything outside of that. By far above and beyond in a way the norm.
And then the slide that you had regarding speech therapy, is that something we're voting on at some point, or was that just to bring it back?
It's just to bring it back. I don't have it to vote today. We could vote on it at the May meeting, or we could wait until that June special meeting and add it to the vote with everything else, whichever you prefer. All right. Any other questions? Chris?
So just kind of thinking out loud here. If I remember Wayne's presentation, And I remember starting on this committee in the end of '23, we had like a little under $6 million sitting in the account, and now we're currently sitting at a bit over 11. So I'm having a hard time reconciling modifying our existing plan to find cost savings when the presentation we got an hour ago says our plan is performing very healthy. So we're already getting savings from somewhere that's affecting that account. So
Yeah, I think the point is just to provide the options like we do every year.
Gotcha.
That this is a normal exercise. We didn't want to neglect that and make assumptions just because the fund was healthy or the projection was flat, that
sure.
there would be no options. So
And Jessica Coberly, for the record, it's also due to outside discussions from this committee or outside of this committee, because we obviously went through all of the contract discussions. And consistently in all of those CBA discussions, there were questions, concerns. Why does our healthcare plan cost us so much? And so that and it continues to be, as we have an open contract, a conversation. And so the discussion is not, oh gosh, we're running out of money in the plan. It's everybody thinking, wow, this is really expensive. Do I really need all these benefits? Because you could pay me more if you gave me less benefits. And so this is being responsive to those conversations, not necessarily conversations that have come up from the financials presented by Wayne.
Right, which I think is why I see the other options offered and having a cafeteria style more beneficial than modifying what our current.
yep. The idea is, I think I've mentioned in the committee for the typical two levers that we pull, right? The
Yeah.
plan design and the contributions. Within that environment, we are simply adding choice and flexibility, right? Just adding choice and flexibility to those variables so that there's more options for employees.
Well, and this presentation is brought forth annually with options for plan changes and deduction increases and such. And although this year we're zero, maybe next year that's something that's considered. Yeah. Meaning 2027.
Leanna, OE3. From a retiree standpoint, I'm trying to understand, like you said, 21% of our plan is the retiree benefits. Is that like a standard, or like, I'm trying to figure out retiree benefit wise, are we offering things that are similar to Reno and Washoe, and the impact it has on our plan? Is it because of that too?
The 21% number, that was simply a percent of the population. So where's the enrollment, not necessarily the cost
Okay.
percent of the plan. We could provide that, we just don't have that on hand today. But as far as, is that within range or norm of other public entities? As you can imagine, most public entities do have a pretty sizable retiree population, right? That's one of the common upsides to a public employer is the retirement benefits. So is Sparks way out of whack with what we'd see? No, not.
And
not-
Jessica
not-
Coberly, for the record, to also clarify with that, in Nevada, under state law, we have to offer the same options to employees and to retirees. So everything you see as an employee option for Reno and Washoe County is what their retirees get as well. So correspondingly, if we're paying more for our employees, we're also paying more for our retirees. So you can say that those are good mirrors of each other.
Thank you.
No other questions? Yeah, it is a lot. It's a lot of information. That's why I will send it out and you can kind of chew on it and talk to your folks. I'm sure they're going to have many, many questions. So if you could send those to me by the 6th or thereabouts of April, and then we'll plan on discussing those questions and or other options that they want to consider at the May meeting. We good? All right. Thank you, gentlemen. They did a lot of hard work on this, and we really appreciate it. All right, next is item number 8, requests for future agenda items. Are there any requests for future agenda items?
Chris Hartwig, IFF, I would request to add to the next meeting a vote for the speech therapy. That vote would entail taking off the 26th visit maximum cap and then adding a 25 visit review, so to speak.
With medical review. Okay, did you get that? Okay. Great. Any other future agenda items? No. All right. Announcements from staff and committee members. Are there any announcements? No announcements. Next is public comment. Is there anyone wishing to make a public comment? If you didn't fill out a card, we can get you afterwards. Is there anybody that, Lee, right? Yeah. Yep, 3 minutes.
Hi, for the record, Lee Layton, retiree. This presentation, retirees have been asking for this for a long time, but I don't see any application. I saw nothing on here that shows where it applies to retirees. There needs to be a portion, 20% of the insurees are retirees. That's a fifth of the whole total thing. And the city doesn't pay for retirees unless it's a special contract that they have when they retire. Most retirees that don't have that pay 100% of the cost of their own insurance. So there needs to be this expanded for the 20% that are paying premiums to be part of this insurance plan, how this whole thing is going to affect them. I can see the employees things, but I think it needs to be expanded. And so how these plans, most of these options aren't going to apply to retirees at all, except for you can maybe lower your premium, but that needs to be explained and expanded. So that's all. Thank you.
Thank you, Lee. Any other public comments? All right, if there is no further business, we will adjourn this meeting at 10:13. Thank you.